Good evening. Thank you very much for this kind invitation. It is the first time that I come to Evora, this very, very nice city. Unfortunately, I don't speak Portuguese. I know only a few words, but they are not words that are just actors like Ronaldo or Mourinho that are quite popular in Italy, but unfortunately, I don't know anything about other words unless obrigado, but obrigado will be at the end. I will talk about pharmacological management of cancer pain. It's a very, very important issues for oncologists. Working? Not working. No. Okay, this is a typical WHO letter regarding the sequence of drugs to be administered in patients with cancer pain. It's a very, very simple concept that is quite important in terms of spreading of the information, particularly in, in some countries. But again, as you know, this concept has never been validated in terms of evidence. This sequence provides non-opioids, anti-inflammatory drugs at the first step, and the weak, so-called the weak opioids in the second step, and the strong opioids in the third step. As I mentioned before, there's no proof that this works. Also, the machine is not working. This is the first. Okay. As I mentioned, the recommendation are based only on expert recommendation, but not proved by clinical evidence with the so-called evidence-based studies in which we have a control with another arms. Now we have a more complex pain situation because people are living longer because of the treatment, but they are living with a bad quality of life because they have more and more problems in terms of also of duration and intensity. They are also more acute pain progression, and we have, fortunately, also more drugs available. So we have more knowledge about the use of these kind of drugs. So we have to focus on the need of flexibility. We have to expand, to improve our knowledge, to individualize the treatment for the single patient, who is completely different from another patient. The first question regards the first step, the use of non-opioids, analgesics, or anti-inflammatory drugs. This is the first step, but for example, we eliminated this first step in our practice because this recommendation, no one said how long we have to administer this kind of drugs that are really have a big toxicity in terms of organ damages, differently from opioids that produce adverse effects, but not exactly organ failure. We tried to change the assumption regarding the use of these drugs. So we used the anti-inflammatory drugs, in this case ketorolac, typical anti-inflammatory drugs, only when adding to opioids to patients already receiving morphine. What we understand from this study is that anti-inflammatory use can be useful, anti-inflammatory drugs can be useful when added to opioids with a limited adverse effect, limiting the escalation index of opioids, and so also the adverse effect, particularly gastrointestinal adverse effects in terms of constipation, providing also some analgesia in patients receiving opioids. Our conclusion is that we can use these drugs as on therapy in patients already receiving opioids when we don't want to escalate further the doses of opioids because there's a limitation in terms of adverse effect, providing some important effect in some individuals. You know that there are some patients who are absolutely responsive to anti-inflammatory drugs, which cannot be negated, the administration of drugs. But you have to control this. If you start with anti-inflammatory drugs and then with opioid, you cannot understand anything about what happened. So it's better to use these drugs as add-on therapy to opioids. So we changed this kind of approach, first opioids and then other drugs, which can be anti-inflammatory or anticonvulsants or antidepressant and so on. The other controversies regard the so-called step 2, the use of so-called weak opioids. I think that we have to overcome these problems because, for example, when we are talking about codeine, we are talking also about morphine because codeine is a prodrug, which needs to be transformed in morphine to provide some analgesia. The problem is that, for example, there's a big variability in terms of metabolization of these drugs because many persons, about 10-20% of patients are not able to metabolize codeine, so to produce morphine. So the question is not exactly the second step, but the flexible use of opioids, including the strong opioids at low doses, of course. We demonstrate this assumption with the low doses of oral morphine, for example, is a question of doses starting with the 15 or 20, 30 milligrams of oral morphine is exactly equivalent to the second step drugs, and they are oral morphine at this dose is incredibly tolerated, so it's possible to escalate the dose very, very slowly. And after 1 month, as you can see in these slides, the dose of oral morphine was 45 milligrams, not more. And we demonstrated the same with the low doses of transdermal buprenorphine and with the low doses of transdermal fentanyl. And similarly, demonstrations were published regarding, for example, low doses of oxycodone. What about the use of strong opioids when low doses of strong opioids or drugs of the second step are not able to control pain? Of course, the decision-making is based on a lot of variability in terms of overall efficacy, adverse effect profile, the individual clinical situation, the pretreatment, the pain intensity, the pain mechanism, the onset, the comorbidity, the interaction among drugs, the abuse potential, the cost, the cultural influence, and the last but not least, the guidelines. However, we know that the guidelines are published at least two or 3 years after they were made among the experts. So again, there's a delay in terms of update information. For example, one debate was introduced some years ago with the use of first-line methadone. Methadone is a very, very nice drug that we have used, studied in many papers, but the first line is problematic because it's a very difficult drug to use. It needs experience on behalf of the professionals, and in these studies published by Bruera, for example, patients receiving methadone unfortunately drop out at more adverse effect. The reason was, of course, the doses that were just half of the oral morphine dose. This, of course, this is not equivalent. The drugs, generally the ratio is 1 to 5. So the reason, this is the reason why they had these results. We used it in the similar study, but in comparison with fentanyl, transdermal fentanyl, morphine, and methadone, which were the drugs we had available at that time. All the three opioids provided good pain relief, no difference in terms of efficacy, but methadone was cheaper, of course, but more difficult to use in terms of zigzag dosing. Fentanyl was more expensive, but had also less adverse effect, particularly gastrointestinal effects, and morphine was in the middle, exactly. So we can use all the drugs if we are able to use that. The principal variation is, of course, the physician who use this kind of drugs. We have to take in mind that the equivalent dose between these drugs when we want to perform the so-called third step are the following. More or less 60 milligrams of morphine are equivalent to 25 micrograms per hour of fentanyl, 12 milligrams of methadone, and so on. What is important that whatever you want to titrate the patients, starting with the 60 milligrams of oral morphine equivalent, you have to assist the titration with breakthrough pain medication, particularly during the first 2 or 3 days before achieving the dose that is able to control pain intensity. But in some cases, it's necessary to accelerate the process. In patients who are admitted in your hospital, for example, with severe pain, lancinating pain, and you ask the patient how much is your pain intensity, and they said, no 10, 20. This is a very, very dramatic situation. Of course, titration cannot wait in some way. If you use oral drugs, for example, and the patient, the final requirement is, for example, about 1 gram of oral morphine, you have the risk to have at least 10 days to achieve the right dose. But we can do the same in 30 minutes. Just giving a bolus intravenously and so testing the patients acutely bedside, as we propose in this paper published in Oncological Journal some years ago. Rapid titration, then rapid conversion to the oral route in patients who have severe pain, dramatic pain, and that cannot await the common oral opioid, oral dose titration. What about when the first-line opioids is unsuccessful? Of course, we have a different option, more or less different drugs, different routes of the administration. We can do both, of course, as, for example, when changing the route and the drug. This way, we can have a big chance of success, about 80% of chance of success, and the explanation are based on some rationale. For example, the different receptor activity produced by different opioids, the different receptor opioid pattern, individual variants, asymmetric tolerance. This is a big chapter regarding the opioid rotation and the dynamic plastic changes of receptor. Drugs which seems to be similar, in reality in the individuals are completely different and will produce a different balance between adverse effects. What about any new drugs available soon or already available or just available now? There are a lot of proposals. Some drugs are on phase 1, some drugs are on phase 2, some drugs are already available again. But one of the most important news, in my opinion, is the dual therapy, the use of drugs with a completely different mechanism that are not as commonly are known super tramadol is another thing. So because in this case, tapentadol has a dual mechanism because one part is opioids, the other part is reinforcement of noradrenergic inhibition on the descending system. So we make two parts in this complex dynamic situation of pain in the cancer, pain in this case, of course. Other advantages, for example, in comparison with tramadol, is that the metabolization is not dependent on the oxidative system with the cytochrome, and so the possible interaction is just conjugation is actually like morphine in some way. Unfortunately, we don't have much experience in cancer because most of the papers have been published in non-cancer patients. We tried to find the solution with the first paper published in cancer patients, an open label, so exploratory or preliminary information about the use of tapentadol at minimum doses in patients who were naive, that is never receiving opioids. The results are very, very good in terms of tolerability, and escalation index. That means that the patient starting with 100 milligrams per day could maintain the dose also after 1 month with a small increase in the dose. We also did not have information about the pain ratio, the conversion ratios with other drugs, because we know that we frequently switch opioids, so we need to have information about what is the ratio, conversion ratio, when we move from one opioid to tapentadol, from tapentadol to the other opioids. More or less the ratio in this study was 3.3. With morphine. That means that 60 milligrams of our morphine are more or less equivalent to 200 milligrams of tapentadol. This is very important because with the confidence with drugs we can do frequently the switching to obtain better responses with opioids. Another point never explored what's happened when we use not tapentadol for opioid-naive patients, but in patients already receiving medium high doses of opioids. We learned from the previous studies that the ratio was 3.3, and so we applied this ratio in these studies, and the patient started with a relatively high dose of tapentadol, more than 350 milligrams. As you can see, the escalation index is very, very low, as actually as we found in opioid-naive patients. This means that tapentadol has a good potential to limit the opioid escalation in terms of tolerance. There's some other information. For example, we tried in a case report in a patient quite tolerant, a patient receiving methadone are quite tolerant. We switched to tapentadol with incredible result. We were surprised because the patient with vertebral pain was able to walk again. This was so surprising that we suggested to our colleague Tony Dickinson in London to apply tapentadol in a typical bone cancer pain model. You know that it's possible to inject a cancer cell and then cementing them in the bone to provide the same model potentially we have in our bone metastasis. What they found was that, again, tapentadol provided an effect completely different from morphine, because morphine was more important for the high-intensity hyperalgesic response, but tapentadol provided a better responses on mechanical and thermal hypersensitivity that is equivalent to the so-called anti-allodinic effect. So providing the potential for, again, neuropathic pain, for, again, providing less tolerance in patients with this kind of pain. I think that we are going to conclude. In our opinion, the mandatory system, which include the opioid therapy, the escalating dose, the multiple shows of opioids and routes, and finally, if the patients are not responsive after different trials of opioids, eventually intrathecal treatment. But we have also the possibility to supplement the opioid treatment with non-opioid therapy, for example, NSAIDs or anticonvulsants or antidepressants, according to the specific individual needs of this kind of patients. So I want to conclude inviting to click this Facebook place that is Mercadante's band, and then I would like, I know that it's so late, to invite to the next Congress in Palermo that is Tra Palliative Care. Thank you very much. Obrigado.